Then we are happy, Kees and I, to welcome you to this session about managing pain in OI, part 1. And the two first speakers are Jackie Clinch from Bristol and Audun Stubhaug from Oslo, Norway. And I think you met both of them yesterday. And today they are going to give a talk, more or less together, about how they work in the multidisciplinary team in a pain clinic in Bristol and Oslo. So, please.
Thank you very much. We will have two brief talks where we will present our clinics and then open up for discussion and question. So time will be spent for that. So I have to present the department as not a pain clinic, but it's a pain center in the meaning of ISP definition, which means that we evaluate and treat patients both in-house and in outpatient units, and we should be able to help all kinds of pain patients. That's the aim from ISP. But at the same time, we're connected with a university, and we have a research group, and we have duties in education of health personnel, both during their primary education, but also, in particular for pain, we have a Scandinavian diploma course for MD specialists, 2-year course, and we have a subspecialty training for specialists in Norway, and we also have a master level education open for everybody, which is a half-year unit in collaboration with a university in South Norway. We are also lucky in Norway to have something called advisory units, which means that we have a little bit of resources to kind of make guidelines, to make digital resources, and arrange meetings. So we have two advisory units, Regional Advisory Unit on Chronic Pain and Norwegian National Advisory Unit on Neuropathic Pain. But I was meant to talk a little bit about our outpatient clinic, which is receives approximately 2,500 applications per year, and we see approximately 1,200 new patients per year. And it's a multidisciplinary department, and we have regular meetings, and the treatment are, in some patients, unidisciplinary, because it could be a simple question about drug treatment, or it is a complicated case with a teenager falling out of school and with a lot of problems, both medically, socially, and psychologically. So it's individual treatment, it's group-based treatment, and it's we try to have something on all fields, like drugs, interventions like radiofrequency, spinal cord stimulation, magnetic, transcranial magnetic stimulation, psychological interventions like you heard about today, acceptance and commitment therapy, or more individually based cognitive therapy. What's very important for us is that the patient has to also commit themselves, so they have to fill in a lot of questionnaires before, and when I read through the results before I see any new patients, I feel that I get quite a good picture of what is the problems and the hopes for these patients. And but it's more like a way to start a conversation and to kind of find a mutual way to a solution. And this is kept in a registry, so we can use it anonymously later for quality and research purposes. I boast sometimes. I say that we are the biggest multidisciplinary pain unit in the Nordic countries, and then I add, and that's not because we are so big, but all the others are so small, and that is in fact a problem. So during the last 10 years, we have tried to build up, and we are 12 physicians now: anesthesiology, neurology, physical medication, and rehabilitation, psychologists, physiotherapists, ergotherapists, and a number of nurses. We are in fact 13 nurses, but most of them work in-house. A typical team for a new patient would be one doctor, one physiotherapist, and then either a psychologist or a specialist nurse. Those three have 1.5 hours in the first meeting alone with the patient, so that means 4.5 hours. And then they have a common meeting afterwards. And then we have a possibility for video meetings with the patient and the primary care doctor, if needed, at any time. That's how we work. In addition to that, what we try to do is to build up multidisciplinary teams with other departments. And that are typically departments who have complex patients, and they have a lot of knowledge about the disease of this patient group, but they may need some aid on the pain management. Then we have meetings with them, and we collaborate with, for example, oncologists, or as you see here now, we have a project with endometriosis and adenomyosis, which is an undertreated group in Norway. We have a regular meeting with the headache group in the neurology department. We have people with pelvic pain after birth, for example. Neuropathic pain, we have a group with children, and we have now also a group with abdominal wall pain, which is also a difficult topic, and where the gastrosurgical, the gastrosurgeons really need some multidisciplinary help. So that's how we try to increase the knowledge. And that means we do not work with one special group. And for OI, I will just mention one project, and that is together with Ariane, which we will meet later, and the Advisory Unit for Rare Diseases. And that is to characterize pain in OI patients using the new diagnostic system ICD-11. So that will start this autumn. And thank you.
Thank you again for asking me to share this, and hopefully we'll have some time to talk as an audience, because this is very much a two-way discussion. So I've got two hats. I'm in Jackie Clinch. I'm in Bristol for paediatric rheumatology and OI, and we serve the south and southwest of the UK. That's on the right with the hoops, sponsored by Wallace and Gromit. And on your left is the Royal National Hospital for Rheumatic Diseases in Bath, beautiful old building. Sadly, we've just sold it and moved up the road to a very new complex. And that's where we've got a national UK pain unit for people across the lifespan. Very much pain-led, disease and non-disease related pain. We treat a lot of young people and adults who have suffered pain alongside their OI, and it's very much an ACT, acceptance commitment therapy based program. So what do we do in Bristol? We've got a lovely team for young people. This is a problem, I think, across the world. It's not a problem. We've got a lovely large team. The problem is, as young people transition into adulthood, that lovely young large team disappears. And I don't know so much about all the other countries, but I know some, and often OI falls into osteoporosis and under rheumatologists, and the wait for a rheumatologist is phenomenal, and access to psychology almost non-existent in our NHS unless you wait a long time. So there's a real disparity, and so this transitional aspect of pain management in any disease is really key, but particularly OI. This is our lovely group that serves a population of about 1 million in the UK overall, and then the OI population from that under the age of 18. So our pain education very much in the OI clinic starts when we first diagnose a young person with OI. And I'd like to think that we take all the family with us on that. It's delivered really well by our OTs and psychologists and social workers. They're really key members of our team. We do a meds review. That's quite easy. There aren't many of them. Richard, I know, is going to speak a little bit about that in a minute. And also, we really have to balance the side effects of meds versus the quality of life of the young person. We also have to really look at sleep in young people with OI and the relationship of that with pain. Preoperatively, it's important for us to give good pain advice, to anticipate pain, and then we also do some inpatient rehab in our children's hospital alongside our other specialities. However, in some young people and adults, the pain becomes so overwhelming they need a more dedicated treatment, and this is where the Bath Centre for Pain Services comes up. We developed it about 25 years ago in the knowledge that there was like this lost population of people who had the doctor had said, actually your disease is really well controlled, and they say, great, but actually I've got pain that's making me so miserable I'm not able to do anything. So again, it's this thing we were alluding to yesterday. If we can't see it, sometimes we don't really believe it or understand it. So this is where this came from. The government, for all its problems in the UK at the moment with the various government iterations, we had really good funding for this. There was a real recognition. We had to show that it was cost effective, that it reduced hospital admissions, and this is what we are. We're now in the dedicated unit on the right, which is great. It's a residential unit where, following assessment, if anyone across the lifespan we and they feel could benefit from one of the interventions we offer, then they stay with us because they come from across the UK and a few from Europe. And this is what we do. We're a large staff, like Arden. We're very lucky. It's very much physiotherapy and psychology led. As a medic, I'm one of 3, and I only spend 1 day a week there. So my job very much is more on the pain education and then facilitating families, particularly I just see the under 25s, to take part in and be part of a pain intervention. I was delighted to hear Kiss earlier talking about a parent's experience. About 10 years ago, we looked at all our data. We have to collect outcome data throughout to keep our funding coming in. And it's good. It's good to do that. It's good to be examined. But what we found was our outcome was good, but it wasn't as good as we felt. And on the background of that outcome, we developed a dedicated parent arm. And so now every young person under the age of 25, not just 18, comes in with their main carer. And that main carer takes part both in the programme but also in a dedicated programme for them. And that's almost non-negotiable because the outcomes following that were phenomenal, not just for the young person, but also for the well-being of the parents. They were able, getting a little bit of the life they wanted for themselves back, as well as that with their young person. So a real lesson for us, and I was delighted to hear it. So we do group programs, we do individual programs. We also, looking at the data, found that young people that were neurodiverse were not served very well by our pain intervention. We see quite a few young people who are neurodiverse, and so we developed a different program for them because they're different needs, different understandings. And research is something that's core to everything, and working with our parent and patient partners is core to everything. And like Arden, we do the educational workshops and research programs. So this is what essentially we do. We do adult programs, and we also, about 7 years ago, developed a young adult brain program as well, working with the team on aspects that the young adults want to get back for themselves. A big thing about universities, a big thing about colleges, and getting into the workplace with their pain, working away where the pain becomes less bothersome. For young adults, and I really hope we have in OIF a dedicated transition aspect to all our work, because you can really do such great stuff, but you can also lose them. So that's a really key area. We also do other pain interventions as well. And we collect lots of data. If you work with psychologists, my goodness gracious, psychologists like a lot of data. And I'd hope it's not too burdensome. It's a worry that for me that it's burdensome because we collect it from the carers, we collect it from the patients, everybody. Anyone that comes, even walks past the door of the unit gets a data sheet. But really important because it does inform absolutely everything. So where are we now? Well, I hope that we continue to go from strength to strength. Certainly we had our 25th anniversary last year. And key to our heart, and something I feel with particularly the OI community and working together, is how can we work to deliver pain intervention and rehab earlier? Because I think sometimes actually things like Bath, maybe Oslo, in some ways we're too late down the line. We have to wait for people to fail. And that's not right. We know lots of conditions have pain as part of their pathway, and we know we need to be there for everyone who cares for young people and adults who have conditions like OI with their pain. So I think getting it early with the diagnosis and having rehab opportunities right from the get-go, local to where people live, not having to come all the way to Bath or to Oslo, is where we need to go in the future. And that's right for the patients, it's right for us, it's right for the families, and also it's right for the purse strings because we empower earlier. So, have we got much time? Have we just
You have 5
rabbited?
minutes for questions. So that's good.
So Arden, do you want to come up as well? We thought, well, if there are any aspects that anyone in the audience might want to quiz us on or tell us that we could do better or
I have a lot of questions, but I don't know how to choose. But I looked up the data from our survey, the recent survey, and I saw that there are 13% of the OI people, adults, who say they are seeing a pain specialist. And
13.
then 13, yes. What do you think about this? And when do you think people should be referred to a pain specialist? And who should see people who have pain other than pain specialists? Who are the best to deal with it?
It's a very difficult question to answer, and the ISP has made an overview of the number of pain centers, pain clinics throughout the world, and at least it was we saw the numbers for Sweden and US and UK, and in fact it's better in Sweden and UK than in the United States. So it's a universal problem that is very few specialists. So what we try to do is to educate everybody, also to educate the primary doctor, because maybe not for an OI patients, but for very many other patients with chronic pain, the primary doctor should be the doctor that is ahead of them. But for smaller groups, it's possible to make more dedicated services, I think.
And yes, I totally agree. And it is a crime that we have not got more pain units across the world. For all our conditions where pain is the most common symptom. Some of the problem, Ingun, lies in us as health professionals, because a medical professional sometimes, rather than thinking, my goodness, I need to embrace the pain rehabilitation here, through no fault of their own, but it's easier to refer to another specialist and compartmentalize your body. And so you might go to the orthopedic surgeons, nothing against orthopedic surgeons, and to gastro, and to neuro, and then to ED, and then ED, then a psychiatrist, and then, do you know what I mean? And you go from ologist to ologist to ologist to ologist, but no one's actually saying, let's bring this together and let's actually look at the pain well-being of this young person or adult and their carers or family. So it's indebted to us as well. But I think in OI, there's a real pathway. You could be really innovative in OI, because there's clearly a great swell of enthusiasm. So between us, we can make it happen.
I think it's time for one short question. It's not short.
I had the chance to study in London community medicine, and now I am in Switzerland, and I hear all the bad news about the economic problems of the NHS, and I was very familiar. I found it an interesting system, you know, being a Swiss. So I would ask you, how do you manage to work with these economic problems?
My word, that's a whole day conference.
1 minute each.
Okay, so I dedicated to the NHS, and we will make it work. We just need to get rid of the current people but they are obviously getting rid of themselves, so that's cool. But the lovely thing about the NHS is if it sponsors, it funds all our work, and it joins us all together. So I think it will stay. We just need a little bit more everything.
But it is a lot of it's easy to get access to newspapers and so on, because it's a huge awareness about the lack of treatments and the lack of access for pain treatment. So we try to kind of keep up the pressure on politicians, and they really have tried to instruct the hospitals, but the hospitals, they have one big sum of money and they have to choose, and so we have to show that we do a good job, and then we get the money, more money.
Yes, absolutely. The ICD-11 is a game changer, I think. Ingan asked if the ICD-11 could help. Yeah.
Thank
Yeah.
you so much for your great presentation, and keep up the good work. Thank you.